Good morning, everyone. And as we end 2023 and go on to 24, that slide is not visible. Can I please call on my panelists, Dr. Tanmoy Mondal, Dr. Priti, Dr. Sangeetha, Dr. Atul, Dr. Satvik, Dr. Sandhya, and Dr. Manoj. I hope all are here. Okay. Okay, I can see all 7 people walking. Excellent. So this is the thing. We have heard 5 abstracts. I'm not going to go into individual detail of each abstract because frankly, we don't have relatlimab, we don't have tocilizumab, we just have surgical outcomes, and I have only medical oncologists on my panel, I believe, right? Is there anybody other than a medical oncologist on the panel? No. So I don't see the point of talking of surgeries. We all believe and trust and have faith in our surgeons, right? So these are the 4 papers and one more paper also. Right, so what I will do is let me start with this discussion on immune checkpoint therapy in lungs, NSCLC. This is from an editorial where they said that you can either use it as a starter, that is neoadjuvant, that is Nadim, Checkmate 816 and Neopredict. You can use it as a sandwich, that is a perioperative. You have AGN, Keynote 671, Neotorch, Nadim 2, Checkmate 77T, or you can use a desert. So Checkmate Keynote 091 and the IM power 010. That's the status of immunotherapy in NSCLC, neoadjuvant and adjuvant. So you have 10 trials sitting here. Right. So first things to first, this is the general good and bad about it. So starting with Dr. Tanmoy. I can't see your also. Yeah. Dr. Tanmoy. I have written you on a list in some list, so I shall follow this list. Dr. Tanmoy, your thoughts, neoadjuvant or adjuvant for immunotherapy in NSCLC?
So I would, if the tumor size is big and they want a downstaging of the tumor, then...
No, who is they? You are the treating oncologist, so who is they?
So maybe surgeon says that
okay.
they want to downsize the tumor and then go ahead with the surgery, then it's a new adjuvant.
So I don't think any lung surgeon would talk of downstaging a tumor. They can remove the lung. It's always the mediastinum that is a challenge for them. So would you, which case would you use it? I don't think you're talking the mic. Can you talk the mic? Yeah.
So I would prefer for an adjuvant immunotherapy.
You would prefer adjuvant immunotherapy. Excellent. Dr. Priti?
So, neoadjuvant versus adjuvant. Neoadjuvant in case when it is not resectable upfront, like larger nodes, and surgeons feel he can resect after neoadjuvant therapy, then yes, neoadjuvant, otherwise adjuvant. If
okay, so
upfront operable, yes, after surgery.
I can see a few surgeons in the hall. I mean, correct me if I'm wrong, the always challenge comes in a 3B multi-station, or if it comes to a T4 with possibly visceral involvement or a chest wall involvement, that kind of thing are you talking about? So if I tell you a patient has got a T2N1 disease upfront, that is a stage 2B or a stage 3, what would you do? Would you say give neoadjuvant or would you say operate?
Adjuvant.
Adjuvant. You would go only for adjuvant therapy. Okay. Dr. Sangeetha?
I think I would like to go with neoadjuvant.
Only neoadjuvant or perioperative?
Maybe neoadjuvant with periop, but neoadjuvant would be to begin with, because I think you're looking at survival here, and like our surgeon says that if you're still thinking of early, I think surgery is feasible.
So feasible, everything is feasible for surgery.
I would probably go with neoadjuvant, not
periop. You would go with neoadjuvant. All right. Dr. Atul?
A T2N1, I think surgery, you can go ahead and then put on it.
Okay. So again, the point is all the trials have used stage 2 and 3A. Alright, that's the inclusion criteria for all the perioperative trials that I'm showing you. So if such a patient comes, would you give neoadjuvant or would you give adjuvant or would you not give any immunotherapy at all? Dr. Atul?
You get the question.
I'm saying all the immunotherapy trials of perioperative have used stage 2 and stage 3A. So if a patient with a stage 2 or a stage 3 comes in MVT, would you tell your surgeons that look, I will give perioperative, or would you say, okay, you decide and tell me what you want to do? Well, effectively that's what the panel seems to be telling me.
No, if the patient is fulfilling all criteria, good performance status, and the surgeon also thinks that doing a...
Okay, fine. Dr. Sandhya.
So the neoadjuvant trials were done on operable
Correct, operable, correct.
So technically here, if there is a patient who is EGFR and ALK negative and has a T3, T4 with or an N2, which are though operable, coming to stage 2B and 3, I would offer a neoadjuvant immunotherapy because there is survival benefit which has come from checkmate.
Very good. So, checkmate, which checkmate has offered survival benefit?
816, the nivolumab.
816 has not given overall survival benefit.
Not overall, yeah, it was even for survival.
Right, so that's why I'm asking what is your endpoint? So Dr. Manoj, just list with you. So are you joining the panel in saying that surgeons decide everything? Because that's what the panel so far sees. Dr. Priya is very happy.
Because I don't think the surgeons find everything feasible. We all look out for the patient. So all the balanced surgeons go for the best. Yeah, NDT is the
Thank you. Yes, Dr. Manoj.
I would like to go for anything. I just like the improvement in PATCI. That is one of the endpoints which has been highlighted in.
So is it an effective endpoint for lung cancer? That's the question I put there, because PAT-CR in breast itself we are fighting over each other. Is it the right endpoint or not? In lung, is it the right endpoint?
Probably we are not in time frame to answer that question in correct way.
Okay.
Probably over after a few years we may be able to.
Okay, fine. So what do you want as an endpoint? Would you want EFS or would you want an OS? What is it that you're looking for when you're sitting and, like Dr. Priya says, we want to have a discussion with the surgeon and say, no, this is good because it gives you EFS or OS. What is it that you're looking for?
I would be looking for OS.
OS.
Neoadjuvant or adjuvant setting, I would definitely look for the OS.
Alright, panelists, rest of you agree? Starting from this side, Dr. Sangeetha, you agree with that? Because you were one of the few who said that you would give neoadjuvant first. So what is it that you're looking for?
So I think in lung particularly that we know that the recurrence rates are high. I think even EFS would, put us forward to start with neoadjuvant. I mean, OS is going to take a lot of time and...
So you're satisfied with the EFS?
I feel in setting of lung, EFS doesn't make a difference.
EFS lung makes difference. What about PAT-CR and major PAT response? Because again, this new terminology of major PAT response has come around in lung.
So I'm not sure if it is really a validated major PAT-CR, but then it's more than 90% necrosis, less than 10% residual. But would it, that there's some data that PAT-CR or it can definitely have an EFS benefit.
Okay, so Dr. Satvik, your thoughts on this? What is your endpoint that you're looking for?
So in the curative setting, I would go for OS.
OS. So OS right now is there only in one study, possibly second or phase 2 study. Everything else is only EFS and trend to OS. So you would say, I will wait, I will not give the treatment. Is that what you're saying? Okay, fine. Yes, Dr. Tanmoy? OS. So OS is there for checkmate 671, which is a perioperative protocol. So are you satisfied with that? And would you then tell us, look, perioperative data is there, I want to give perioperative. Okay, fine. So from the viewpoint, if any other surgeons are there other than Dr. Priya, who can, any challenges in operating patients who have undergone a neoadjuvant in lung? I don't think there's any real challenge with immuno from what we have seen. There were 2 papers presented today, both showed that in the AGN and the other one, there was not much difference. So, Dr. Priya, any thoughts on this? Difficulties in surgery after immunotherapy?
So, we did discuss it today that yes, practically there are some issues post immunotherapy regarding the nodal dissection. Sometimes they are quite adherent and...
Okay, is this something you're seeing in practice? Because in the trial they didn't find such difference.
So, I think that with time, as time passes, we'll be able to see more clearly.
Okay.
We have been seeing it in often cases that post immunotherapy sometimes the nodes become quite adherent, but we'll have to see how our patients progress.
Okay, but you feel that it is not a major challenge, you're okay if somebody says that, because this is what the data is. Now we can see the checkmate.
So I don't think that there's a major challenge. So we'll have
it's not a major challenge.
We'll have to go along with it. So the difference is that all these articles probably are not from India. So Asia has a lot of nodes anyways. Tuberculosis or all that. They might lead to more adhesions and fibrosis. Might lead to more difficulties, but I think with technical advantages like surgeons have grown till now, we'll be able to overcome that.
Excellent. I think that's one of the major things that was settled. 2 of the paper abstracts discussed showed the surgical outcome. Now, interesting point about the surgical outcomes is that when you look at this slide, this is the slide which I prepared, so you can see the resection rate. Now, the resection rate ranges anywhere between 80 to 90%, with the exception of the 77T, which came just recently, which showed a 78 and 77. Otherwise, your resection rates are close to 80 to 90%, which is not that bad, because that's what we expect. There will be patients who turn out to be inoperable, there will be patients who turn out to have side effects. So, at least as per the data, it seems to be okay. Right? So, again, if I can come back to my panel, Dr. Sandhya, starting from you, looking at the PAT-CR and the MPR rates, you're getting a PAT-CR of around 20. You know, let's forget the one or two of the outliers, but it's by and large around 20 to 25%. And the major pathological response around 30 to 35%. So again, you're satisfied with this, Dr. Sandhya?
Yeah. So in neoadjuvant chemotherapy arm, the PAT-CR rates are almost minimal, or you would have seen 2 to 3%. But with the addition of immunotherapy, it has shown a PAT-CR rates of around 20%. But would this really benefit in near future with the OS benefit? We are not very sure about it.
So I've shown you two papers there. You can see both the NADIM-2, which is a phase 2, and the Keynote 671, which was published in this year's ESMO. Look at the hazard ratio, it's 0.72. The other place is around 0.43. So phase 2, but 0.43. So you are having two trials which are showing OS advantage. So is this question still needed to be asked, that if it shows advantage, or are you satisfied with this? The FDA clearly is, so I'm asking you.
So I feel it has not exactly translated into a survival benefit yet. We need more data to support this aspect.
Okay. Dr. Manoj, do you agree with this?
Can you repeat the question?
I'm asking you, CM671 is showing you OS advantage. It's showing you a 0.00517, it's showing you confidence intervals within limits, it's showing you 0.72. So what are we waiting for? Why is everyone saying let's wait for more data? The AGN is only 25 months, 18 months or 12 months follow-up. We don't have Neotorch is only 18 months. So compared to 36 months follow-up with KN671, and you're getting OS advantage. So are you still hesitating? So why are you hesitating for?
No, I'm already in for NSAT.
You're for NSAT, for perioperative. Okay, excellent. Somebody is for perioperative. Very good. Dr. Priti?
Yeah, we have this data where we can see the PAT-CR is supporting overall survival. Yeah, there's one data. We need more data to support whatever we are getting.
So you need more data. The more the merrier. Okay, very good. Dr. Tanmoy, you said the same thing. You need more data. Dr. Atul? More data? Or you're satisfied?
No, more data.
More data. Satvik? More data. Okay, so for everybody else in the hall who accused medical oncologists of jumping the gun, we are not like that. We want more and more data before we are going to give any immunotherapy. Great, that's what it is here. Now, interestingly about PD-L1, so starting from Dr. Sandhya, do you think the PD-L1 matters? Because again, I'm showing you now 4 trials. 2 are adjuvant, 2 are perioperative, and you see that as the PD-L1 increases, your benefit increases. Now, forget that pearls, I don't know how to interpret that, why one subset suddenly veers off and says there's no survival advantage, but otherwise, the PD-L1 increases, your benefit increases. So,
yes, so far whatever data we have, especially from IM Power 010, you will notice that as the PD-L1 increases, that more than 50% you have more benefit rather than less than 1%. And the only data which has not shown any correlation with PD-L1 is the Adjuvant pembrolizumab. So I would say that PD-L1 definitely we have to take into consideration when we are choosing for neoadjuvant or adjuvant therapy, especially with immunotherapy.
okay, so Dr. Manoj, you said you're okay with the perioperative. Now we have KN671, 77T showing a trend to survival. AGN is frankly only 18 months update is there, 12 months update is there. So do you think it really matters now which IO you use, or you want to stick to the trial and say I give only pembrolizumab? This is not a sponsored session, so I'm free to use whichever name of drug I want. But you, so are you?
Yes, I would like in principle, if we say let's say immunotherapy is working, so irrespective of the agent, definitely we initially go for the data which is
okay. So you are okay with it, but you are waiting for the
same. Yes.
Fair enough. Dr. Sangeetha, question to you. What if you get PAT-CR after neoadjuvant? So you wanted to give neoadjuvant. You have given your 3 cycles or 4 cycles of whatever you want, nivolumab or pembrolizumab, and you get a major PAT-CR or a PAT-CR. What next? Would you continue your immunotherapy or would you stop?
I don't know if I have an answer to it.
Okay,
but at least I think if the complete PAT-CR, whether to give the adjuvant as a, be a choice, but would be a discussion.
Okay, Dr. Atul?
They continued, so as of now I'll continue.
So there is CM816 which said that if you're getting neoadjuvant nivolumab which gave you good data, it was again no OS, but it was showing you advantage. So would you still say I want to continue?
Nivolumab I'm using, obviously we don't have to go ahead and complete.
No, nivolumab not obviously, because you have 77T which has done exactly that. So this is why the lung is so fun. You have 2 trials, both have used different things. So Anyway, anyone wants to do MRD testing? We are sitting in Mumbai, which is the heart of sending molecular test at the drop of a hat for every patient and every indication. So, anyone wants to do MRD testing and ctDNA testing for these things? Yeah.
There was data about the circulating tumor DNA cells. The higher the chances of recurrence, so they may be there the patients who would definitely benefit.
So again, as she points out, in IMpower 1, they have shown the circulating tumor DNA data where they said that if ctDNA was positive, there's a higher chance of relapse. But again, what it means, we really don't know. Any other biomarkers, we saw in one of the abstract presentations, the TGF-beta high levels would correlate with a poorer prognosis. I don't know what that test is or who does it, so I'm not even looking at that. So more interesting thing is this. Now, this slide I borrowed from Dr. Tony Monk's lectures from ESMO this year. Could not take official permission, but I'm acknowledging that these are his slides. So as the first one is from CM816. The top two curves are actually those patients who achieved the PAT-CR, whether they got Nivo or whether they got chemo. The bottom two is the one who did not achieve PAT-CR. Same way 671, the top two curves are from those who achieved the PAT-CR. So there is actually not much benefit if you continue immunotherapy. Right? This is the interpretation I made. Now what was his interpretation was that if a patient remains MRD positive or does not get PAT-CR, why would you want to continue giving immunotherapy if it did not work well in the first place? So his concept is, if it is working well, continue it for continue the full 1 year therapy. Do not give it if the patient is not achieving a PAT-CR. Try to change your treatment. I think, but in practice, I don't know whether we should follow this. Dr. Sandhya, your thoughts on this? Would you agree with this? So if patient achieves PAT-CR, he is doing well, continue it for 1 more year. Or would you want to change? No?
Yes.
Catherine.
So, coming to the perioperative part and what exactly you have pointed here. So, I will talk about biological paradox. If two agents, that is immunotherapy and chemotherapy, have not worked to the extent that we were expecting for a pathological CR rate, just continuing one agent beyond surgery may not help us. And something which has worked with a good MRD, I suppose it will work further. So, if I choose a perioperative therapy, something which is working, I would like to continue.
So you agree with Dr. Tony Mock saying that if it works, let it continue?
Yes.
Excellent. Dr. Tanmoy, your thought on this?
So if it works, so for chemotherapy actually we have that various, either 3, 6, 4, whatever number of cycles that matters, but yes, immunotherapy I would continue.
Immunotherapy you will continue. Okay. So that brings you to the immunotherapy adjuvant studies. Again, you have the Pearls and the IMpower which have done. Now remember this. All these studies of adjuvant have used 1B also, more than 4 cm. Right? The perioperative studies have all used 2 and 3A. They have not included 1B. And none of the studies have included 3B. So that's the other thing we need to remember. 3B is not included in any of the studies. These are the two which have been published. And again, as I was telling you, the benefit is there in the IMpower, where the PD-L1 positivity seems to correlate with a better response. So that's what the data we have now. As usual with all ETISO trials, they are sliced into less than 1, more than 1, 1 to 49, more than 49, and so on and so forth. The best advantage is more than 50%. So this is what is my take on the whole subject. If you're 1B more than 4 cm, surgery is what we would offer, and adjuvant IO I would possibly offer at this point, just based on the ETISO data. But again, I would be happy to give it only if it is PD-L1 positive. If you have a stage 2, 3A, surgically fit patient, I would give perioperative, where I am planning to continue my immunotherapy beyond surgery. If the surgeon, for whatever reason, does the surgery, I think it's okay, PD-L1 positive, give adjuvant IO. If patient requires rehabilitation or is borderline fit, definitely neoadjuvant or perioperative is the way to go. 3B single station, which is operable still. I think this is where perioperative has a role, though it is not included in many of the trials. Multi-station, as of now, there is no role for debulking, there is no role for downstaging, there is no role for reducing or debulking. As of today, you send them for CTRT followed by immunotherapy or not, as you want. But at this point, 3B, multinodal, the surgeon sends you saying that, okay, just do something and reduce it, I'll do an operation. That's not accepted as of today. I think that's the take-home message from me. This is the Alina study, the last one study, which is again very interesting about the alectinib. So quickly from all the panelists, Dr. Sangeetha, Alina, yes or no?
Yes.
Yes. Why?
I think it is definitely giving, it's at least giving us the benefit.
Okay. So you're looking at the disease-free survival in 2 and 3A. What will you do in 1B? There's a big WhatsApp fight going on yesterday about this, which I do not agree with. But what will you do in 1B? Because again, they have done the same thing. They have done 2 and 3A and then given you one more subset saying 1B, where if you see it is not working. At least for me, it is not working.
Yes.
So you would stick to 2 and 3 or you would stay in 1B also?
Stick to 2 and 3.
Stick to 2 and 3. Okay. Dr. Atul? Alina, yes, no, with subset?
Yes, obviously
Yes.
six to stage 2 and 3. Yes.
Stick to stage 2 and 3A. Dr. Tanmoy? Yes? For all or 2 or 3A? 2, 3A. Okay. Dr. Satvik?
Looks promising as of now.
Okay. Will you give it Monday morning? Today is Saturday. Yeah. Monday morning, patient comes as positive. Yes,
because
no?
with EGFR, also earlier EGFRs, we have seen that the
Adora is what
Adora is
benchmark.
for osimertinib, but for the earlier EGFRs.
Alright. Last 30 seconds more, we'll close up. The Preeti? Yes. All for all. Okay. Stage 2 and 3A. Manoj?
Absolutely yes.
Absolute yes. Okay. Dr. Sandhya?
For stage 2, 3, yes.
Okay, perfect. I think I have convinced everybody, though in practice I think everyone in 1B is still also giving his positives. So thank you everyone and thanks for the lovely panel as always. Thank you.